This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. Now, how to convert to a manual small incision cataract surgery by aborting Phaco when we already made a 2.8mm sclerocorneal incision? Well, let's find out. She is an elderly lady with hypermature cataract, and as we expect in these long-standing cataracts, she has this calcified and fibrotic capsule. Overall, the capsule looks to be unhealthy and also anticipating zonular weakness in this eye. So this is a patient wherein I'm not sure whether I will be performing phacoemulsification. That decision will be taken only once the capsule exercise has been done and assessing the intraoperative status of the zonules. Intracameral Lignocaine is used under the air bubble, followed by staining of the anticapsule with a trypan blue. Once the staining is done, the extent of the fibrosis of the anticapsule is very well delineated, and this is the area where I expect some problem. I'm sitting temporal. The plan is to perform temporal phacoemulsification. Now, because this is a situation where I'm not sure Phaco would be safe enough in this eye, I'm consciously making a scleral incision here. It is about 1mm posterior to the limbus, and then using a 2.8mm keratome, a sclerocorneal tunnel is created, and I have this internal entry. So we have a 2.8mm sclerocorneal tunnel, and my plan is to perform phacoemulsification through this incision itself. In the event I decide to abort Phaco, I plan to extend the same incision and convert it into a 6mm sclerocorneal tunnel. Let's see how things turn out. After filling the chamber with OVD, I puncture the anticapsule with 26 number needle, and as expected, there is an egress of loose cortex. The plan while performing rhexis in such eyes is to circumvent the area of the fibrotic zone, and I'm trying to incise the capsule beyond the area of calcification. The loose cortex is gently irrigated out so that the visibility is better. Once the fluid cortex is all irrigated out, OVD is injected above the anticapsule. I'm using Dr. Haldipuka's capsurexis forceps to grasp the flap and then to tear it. Although the tearing edge has gone very near the equator, I was fortunate to pull it back, and eventually the capsurexis could be completed, although the rhexis is eccentric and one part is extending towards the equator. Now, looking at the situation where I have a mobile nucleus and the capsule is not so healthy, in this situation, I consciously decided to convert it to manual small incision cataract surgery. Let's see how it was done. So I'm going to fashion a conjunctival flap which is on either side of the sclerocorneal incision, so that the scleral groove can be extended on either side and then the tunneling could be performed. At this moment, I realize that the patient is still on topical anesthesia, so I'm giving 1 ml of lignocaine into the posterior space using a blunt cannula. This will make the patient much more comfortable, and there is going to be some amount of bleeding as we cut the episclera, and I'm not going to use any cautery. Of course, it can be done. I'm just asking my assistant to irrigate out so that I can see when I'm fashioning out the scleral tunnel. The principle here is to enlarge the scleral groove on either side of the pre-existing 2.8mm scleral incision, and it is being done in a slightly frown incision with the overall length of the incision being about a 6mm. And once the grooving is done, I'm going to make a posterior groove just to help me to stabilize the globe, and then using a crescent blade, I'm going to fashion the scleral tunnel on either side of the original sclerocorneal incision. We don't have superrectus suture, and the patient is still moving his eyeballs to get a firm grip. So I need to find a way of stabilizing, and this is my way of stabilizing the globe. So once the globe is stabilized, we can very easily perform the scleral tunnel on either side of the incision. The key here is to start with the tunneling from the original incision itself and then extend it on either side. In just a couple of minutes, we are able to perform the sclerocorneal tunnel. Again, the visualization is a challenge, and a constant irrigation by your assistant is going to ease this out and help us to see better. Using the 2.8mm bevel-up blade, the internal opening is enlarged on either side so that we have a 6mm sclerocorneal tunnel. So the tunnel is extended on either side of the original 2.8mm incision. Under the cover of OVD, I'm using 2 Sinskey hooks to gently mobilize the nucleus out of the capsular bag. I can't emphasize more that every surgeon should learn this technique of using 2 instruments to mobilize the nucleus out of the bag. I believe that this is a technique which should be learned and mastered by every surgeon. I'm going to divide the nucleus using a snare in the antechamber. OVD is placed behind the nucleus and in front of the nucleus to protect the endothelium. And this snare containing a metallic wire is introduced into the antechamber in a slanted fashion, and then it goes in and hooks the equator of the nucleus. I adjust it so that it is placed exactly at the center of the nucleus, and then the strings are pulled, which results in an effortless cracking of the nucleus into 2 heminucleus. Each of these heminucleus would be measuring about 4 mm in their widest part. Under the cover of viscoelastic, my preferred technique is to use a Vectis and a dialer and extract them out manually using a Phaco sandwich technique. The remaining heminucleus is dealt in a similar way. So dividing the nucleus in the antechamber using a snare is a very effective method so that you can remove a larger nucleus through a smaller incision. So I usually use 2 techniques to divide the nucleus. If it's in the bag, I use a pre-chopper to divide it in the bag, and in the antechamber, I use the snare. And both of them have their own advantages. The dividing in the bag using a pre-chopper becomes a little bit complicated whenever we have situation like this wherein the bag is not healthy. In such situations, I prefer the snare to manage the nucleus which is in the antechamber. Whatever little bit of cortex is there is aspirated out and time to implant the lens. I'm going to implant 6 mm PMMA lens in this eye. The bag is filled with OVD and the PMMA lens is gently manipulated into the bag. The OVD both in front and behind the lens is aspirated out. The side ports are hydrated and time to close. I always prefer to close the conjunctiva either with a glue or a suture. Here I'm using an 8-0 vicryl suture. The bites are taken from the undersurface of the conjunctival flap so that the knot which is produced at the end gets buried inside. That was it. The case is done. These are the next day pictures. The cornea has some amount of edema which resolved in a day or 2. This was a small film which highlighted the concept of making a sclerocorneal tunnel for Phaco and using the same incision to convert to manual small incision cataract surgery if the situation demanded. That was it. Thank you for watching and hope you found this helpful.